there's a lot of focus on things that will prevent decreases, things that will cause decreases in EGFR after surgery. And I think we at UCSD with Dr. Derwish, we really considered what are we missing? What things are improving EGFR? It was very interesting. What actually brought us to this question was we saw a few patients who had hilar masses that experienced increased EGFR. So we were thinking, oh, maybe the location of the tumor had a big impact, which unfortunately we didn't find that renal score didn't have a very significant impact on improving EGFR after. We have a large database. We took about 3,800 patients who underwent partial nephrectomy for relatively localized renal masses. We found that of those 3,800 that met our criteria, about 600 met the definition for increasing EGFR after nephrectomy. And we kind of wanted to see if we stratified patients based on how their EGFR changed after surgery, what could we find? What non-cancer mortality could we find? What non-cancer survivals could we find? And then what factors lead into increasing and decreasing EGFR in these three groups? I think what every urologic surgeon knows is, the quality of the surgeon, the quality of the surgery is very important, and nothing goes beyond that than clampless versus clamp technique. And it does show that you want to protect the patient, and we want to clamp patients to save blood loss, make it easier for the surgeon to get it through. But there seems to be an increased likelihood for EGFR improvement for clampless technique. But that's something that is user determined, operant determined. But something very interesting is that clear cell RCC had one of the biggest impacts. And we look a lot at different kinds of RCC in our lab about what factors go into local inflammatory diseases, what factors go into what affects the kidney long term. Clear cell itself, many studies have come out about CRP, how clear cell and increased CRP has this trend towards causing this local inflammatory process. Patients with clear cell with increased CRP have these decreased or worsened long-term mortality, survival, metastatic factors, recurrence factors that we've been trying to look into more and underline. And we think it's very important to see that the different histologies, particularly clear cell, might have a bigger impact in these local inflammatory factors. At the EAU, one of the great panelists asked, clear cell does have this pseudo capsule, which might be causing like itself a physical blockade, and which might be true. It might be definitely something to consider more. More in-depth histologic examination could be important. And again, we saw that, hilar mass, for instance, was not highly associated with an increased EGFR after surgery. But this just comes to we need better data. We need more data looking at things that will make our patients' lives better after their surgery. So it seems that also another factor is clear cell tends to be a bit more aggressive of a cancer than some of the other histologies. Not the most aggressive, but it tends to be more aggressive, which could play a big role. A lot of articles are coming out about its increased, immunogenic factors, causing local inflammatory process and body inflammatory processes. And these are all things that could be affecting the kidney in ways that we're not seeing on histology, that we're not seeing in gross examination either. But other factors, we published a paper on the obesity paradox. In our data, we showed that in clear cell renal cell carcinoma, the obesity paradox doesn't hold true for our patients. Again, a single study, a few institutions, but still it should be taken that the status of the patient is also very important. Looking at some of the other abstracts that were presented at the EAU this year, diabetes was a very important factor in EGFR and decreased EGFR after nephrectomy. And we show in our study that EGFR hazard ratio of 0.07, which was still significant, p-value less than 0.05, had a decreased likelihood for EGFR improvement. So although obesity itself may not be the key factor, confounding variables of obesity, diabetes, heart rate, cigarette smoking, these could all be factors leading kind of synergistically or, parasitically against the patient and affecting their kidney function before and after surgery. Being more involved with the patient before surgery, making sure they're healthy, making sure they're doing these lifestyle improvements before surgery is very important. Also, good planning, coming to it with a good understanding of where the mass is located, the best way of getting to it, and also looking at other ways of kind of mitigating damage. For a lot of doctors, a lot of physicians, they try to do tumor shrinking neoadjuvant therapy before surgery. And again, this study was with local renal masses, but just to think that the less you cut, the better. So the more we can reduce tumor burden before surgery, the more we can improve the daily health of our patients. This doesn't just end at urology. This starts with your general practitioner. This starts with what you're eating at home. This starts with habits at home, taking care of your diabetes, making sure your HbA1c is low. It's as much as we would love surgery to be the end all for all of these subjects, it really comes from the home. It really comes from grassroots movements, making sure the GP understand what's going on, making sure they understand what's going on. I mean, how many times have we told patients like, oh, your bladder cancer is being fed by your cigarette smoking? Happens all the time. Same thing here. What you're eating, all of these things really affects how your body fights the cancer and how the tumor is then leaching off of our bodies. So having a good understanding of the radiologist's approach, how he sees it, what are the lines of it, then going in, taking it out, and then the follow-up care is also very important, making sure that patients are getting up as soon as they're done with surgery, safely, of course, making sure that they're eating healthy, changing those habits. I think we need to look at a very, as you're saying, we need to look at a multidisciplinary approach, get everyone involved, them, their families, their loved ones, their friends, whoever we can, and really create change from the inside of our patients.